welcome to our chat about the menopause and the perimenopause. And I want to introduce you, if you don't know her already, to Dr. Claire. Do you want to tell us a little bit about yourself, Claire?
Yeah, it's probably the best thing. It probably leads into the conversation we're going to have a wee bit better, doesn't it? But so I am Dr. Claire. So I am a medical doctor. I qualified in 99. So I was saying 20 years, but we're probably up to about 22 years now of being a doctor. I originally trained as a psychiatrist, and then I moved over into general practice. So I became a GP in 2006. So we're probably about 15 years as a GP. And that's really where I've got my biggest experience, I guess, in treating perimenopause and menopause, because most people will visit their GP whenever they have symptoms, particularly whenever they're kind of wanting to have this conversation about medication or not. And I think part of what Nicola and I were talking about beforehand was sometimes that conversation has been unsuccessful, and there's been a lot of media out there about bad conversations people have had with GPs, but most people will go and visit their GP if they've had perimenopausal or menopausal symptoms. So I have worked as a GP partner for many years. My main work at the minute is with Cambridge private doctors, and I work there with a lady called Imogen Shaw. So she's in charge of the Cambridge Menopause Clinic. Most people maybe link here across to Cambridge, not necessarily so with Nicola's Athena Project, but Imogen has been involved in writing the NICE guidance to do with menopause, and I've worked alongside her now since I've lived in Cambridge, so the last sort of 5-6 years. So she also works with Nick Panay, who is another great doctor if you're looking for people who can help you through the menopause. So she keeps us up to speed at the Cambridge private doctors with what we do with our menopause care for ladies. And I actually think we're really lucky to be this age at this time, because I think never before has there been this amount of attention given to menopause. I think we're hitting social media at a time when people now feel happy to put these sorts of conversations out there. And I certainly feel, in the perimenopause myself, putting it out there and sharing a little bit, that this is the time where we're going to get the best care, because previously nobody really talked about it. And I know the kind of conversations, the sort of things that I think we thought were going to come up today, Nicola, was to do with kind of where HRT has come over the years from being something that was this wonder drug. And I certainly remember it sort of maybe around my mum's time, this wonder drug that every woman went on. And then suddenly there was this research that came out to link it with breast cancer, and everybody then didn't want to take HRT, and there's been a sort of a 20-year lull really of people not being sure whether they should be on HRT, going to see GPs who are not keen to prescribe them HRT, and a lot of women then struggling. So this is where we kind of come to with this kind of conversation, isn't it? Is to do with what are our kind of choices, what are our decisions. We now want to be given the information so that we know what the right decision for us as an individual is. And part of what I do as well is I'm a GP trainer, so I teach GPs or doctors to be GPs. And I know that some people have had kind of conversations to do with maybe GPs aren't trained well enough. Certainly you can't walk into your exams as a GP trainee these days without knowing about menopause. It certainly is taught. But I think that there are still some cautions out there, and I think there's a definite divide between people who maybe are old school when it comes to whenever they would have learnt about menopause, and younger doctors coming through who are maybe more up to date and kind of are maybe more approachable and more able to have these conversations with.
And I think one of the things we want to do with this session particularly is to give women the information so that they can go to their GP and say, could I be perimenopausal? Because I think what happens is often women go to a GP with one symptom that it's new to them, and they don't recognise that it's perimenopausal, and might be offered antidepressants or lifestyle advice when actually there's a whole bigger picture. And that was my personal experience. I found that I fluctuated, and things that I did present with have now settled. And I think a lot of that is to do with coming off contraceptives. after many, many years and having babies and breastfeeding.
Yeah.
But one example would be I was talking about really low periods before my menstrual period. So the week before, I would be really depressed, really low, really hard to get myself out of bed, totally unmotivated. Like I wanted to quit my job, really low.
Yeah.
And I was offered antidepressants. And I said, what, for the 10 days, the week that I'm really low? And she's like, no, for the constant, ongoing. And I said, well, I'm not depressed. So then I left not knowing quite what to do with myself. And another symptom I had, which I presented with perhaps a year later, was incredibly heavy periods. And no one suggested to me, I saw 3 different doctors, females, no one suggested that could be a perimenopausal symptom.
Yeah.
And again, that settled. So this would have been nice to have had it suggested. Now I know so much more.
Yeah.
I put it together.
But I think there has to be something to be said about you now look at these lists of things that we can have as part of the perimenopause, and they are massive. And those can also be signs of other things going on for us as women. And sometimes it doesn't become obvious until you're a little bit further down the journey, until you're kind of a little bit more definite. As you say, when you start to develop heavier periods, then that should really have been something that maybe would have highlighted that to someone.
Yeah.
But in that beginning, is it PMT? And yes, maybe using an antidepressant is the right approach for that. But it's that difficult thing. One of the things that I was getting was bleeding gums. I did not think bleeding gums had anything to do with perimenopause, but suddenly when you're starting having night flushes and having flushes and sweats, it becomes really obvious that actually this is part of this bigger picture. So it can be very easy for us to kind of be, why did somebody not pick this up? But actually, when you look at one of the symptoms in that list separate from the rest of them,
and
it's very hard for a GP to necessarily pick that up.
That brings me to one of the points we wanted to talk about, is how is perimenopause diagnosed? Because like you say, some of the symptoms can present perhaps the same as thyroid dysfunction or something like that. So do you want to talk a bit about how perimenopause is diagnosed with women?
Absolutely. So I guess one of the things that people always ask about are blood tests to do with diagnosis of perimenopause. And what we know now, and what the GP will be aware of, is that we don't need to do blood tests in order to diagnose perimenopause. So if you are over 45 and you present with particularly the typical symptoms of perimenopause, but equally now, once you're over 45, there should be an assumption that even some of the less obvious symptoms, like your PMT, like your bleeding gums, like just mood swings, low mood, low energy, all the things that could be to do with things like your thyroid, they're more likely to be to do with the perimenopause. They don't need to have a blood test done. We do blood testing if you're under the age of 45, but what we also know, even in that age group, is that often you will end up with normal blood tests. And again, I think this is where unfortunately GPs have come to bad press, is that people have been referred for blood tests, they've come in with normal blood test results, and then they've been told there's nothing wrong and off you go. Whereas again, what we now know and what the advice is, that actually this is very symptom led, and that you can be perimenopausal without your blood tests showing anything. And I think that's where we need to be really cautious. And I know some people go to kind of fancy clinics where they will be offered very expensive additional tests that even your GP wouldn't do. And again, if you look at the guidance and you look at the research out there, these extra tests don't gain us anything. What we need to be doing is spending that time speaking to the individual who comes in the room, listening to their symptoms and giving them the information about perimenopause based on the symptoms. So it's very much symptomatology, if you can say that, rather than blood test led. There are certain reasons that we do blood tests, but they are not needed to make that diagnosis. So the diagnosis is made certainly in someone over 45 by symptoms. Under 45, we do some blood tests just to double check some other things in the background, but over 45, no blood tests are necessary at all.
That's really helpful. So then going from there, if a doctor or when the doctor decides that and you agree that you think you are perimenopausal, how do they then decide what treatment you need? So can you talk a bit about the combination of hormones that are offered, and perhaps even go into the ways that the drugs are administered, because that can be very new to people?
Yeah, absolutely. So I guess it needs to be very much an individual approach. I think you are addressing one of the biggest factors in this with the Athena Project. So obviously, we're talking about HRT today, but let's say a few lines about the fact that lifestyle makes a massive difference here. So when we look at kind of things that can help us through the perimenopause and through that kind of transition, we know top of that list is being active and looking after ourselves physically. So having a normal body weight is really important, so that we know that obesity, unfortunately, is linked to poor outcomes with perimenopause. So getting ourselves fit and healthy is really important. We know that nutrition can play a part, and there are certain things that we know can be really helpful around the time of the menopause. So we know things like your omega-3s, or what I always tell people to really try to get more of into your diet, and to get your heart healthy, but also to kind of help balance some of the hormones in the background. And also soy products come up time and time again when I look at research, not with a massive amount of evidence behind them, but there's enough said about them that I always say to people it's worth trying. So some of the things that you will read about that are more natural kind of remedies don't always have the evidence in research to back them up, but that doesn't mean that it's not worth trying for you as an individual. So I always say it's worth trying these things, but keeping yourself fit and healthy. I often say alcohol is a big problem around this age, and I think that's a difficult conversation to have, but it can make a massive difference to people's menopausal symptoms. Somebody can go from drinking to not drinking, and their flushing can stop. So it's a really something, it's a conversation to have with yourself about what your priorities are and what you want to do, but that can be a really big thing that you can make as a lifestyle change that can make a massive difference to your symptoms that you're getting.
As well as reducing stress, right? That's a key one as well.
So reducing stress. I mean, that's really difficult. We talked about this, didn't we, before we came on air? Like, what happens to us at this age? We have children, not everyone, but we have children who are at that stage where they're becoming a bit more tricky. that we're managing households. A lot of us are trying to set up our own businesses. I mean, how many people do we know our age in Cambridge who have just set themselves up? They're managing their own business, they're managing the home, they're managing children, and then these hormones come in and wham us, and managing stress is very difficult with bearing in mind all of that. But yes, there are things that we can be doing. I think you've had Lucy on board doing some of her kind of breath stuff with you, and again, I think exercise is a really big thing in that. Spending time with other people, connecting, getting outside in the fresh air. There's a massive list. We do all of that with cognitive sports therapy. That's our thing.
Exactly. And then we get to this stage in the Athena Project, week 4. Hopefully some of the symptoms, and I know they have improved. But what if you've still got an edge that's there and you need some extra help, or just learning now about what you might need in the future? What's available?
Okay, so let's run through the options we've got. If we kind of start with symptoms, and this is the kind of biggest thing because it's not the one size fits all. One of the major symptoms that people get around the time of the menopause, and I know that you've addressed it this week, and sometimes it's a uncomfortable topic, is sexual side effects. So we know that a lot of women will get vaginal dryness. We don't like to talk about it, but it does happen. We get pain during sex. We get reduced libido. We get in that same area, we get a lot of women, and again, it's one of these symptoms that isn't always necessarily understood to relate to the menopause, but it does, is recurrent bladder infections and urine infections. And all of that is coming from the atrophy, so the skin changes that are happening around that area down below, which then the skin becomes much thinner, and therefore you're more prone to infections and dryness. So if that's
just to add to that, itching around the vulval area, that's another one that's not particularly connected to menopause, I think.
So people will think that they're getting recurrent thrush, and they might keep going to the chemist and getting treatments for that. So absolutely. But if that is you and you're in that kind of pattern, but actually everything else is okay, then I would be suggesting that the best thing for you to be taking is a topical estrogen. So that's estrogen that you use vaginally. It comes in 2 different forms. So it comes in a pessary, a bit like a tampon, or it'll come in a kind of a cream. And I would generally suggest everybody that you get the cream, because what you can do with the cream is you can use it outside of the vaginal area, because it's never just the vagina that's dry if you're getting symptoms in that area. So you can use it around the end of the urethra and around the vulva, and even around the anal area if you've got some tenderness around that area. It can be life-changing. And if those are the only symptoms that you've got, then that's the treatment for you. So I think that's the simplest one. And whenever we get into the conversation about breast cancer, not breast cancer, because it's there in the backs of all of our heads, most people will say, and I think the most latest guidance, because it changes all the time, but I read it last night to make sure I was completely up to date for this conversation, is it does not relate to breast cancer. So you can safely use that for symptoms that you've got in that area. If we then kind of, sorry.
I was going to say exactly that. So it's been shown not to have any risk of side effect, and also can be used alongside other HRT.
Yeah, absolutely. Absolutely. So then if we kind of then get into, again, then the conversation is to do with you as an individual. So if you are under 45 and you are therefore, I guess, young to be going through perimenopausal kind of symptoms, one of the next options that you would have in order to help you hormonally as a treatment would be to be on a low dose combined contraceptive pill. And it's interesting you talking about coming off contraceptives, but what most women will have done at the end, I don't know whether this is you, is that we will have been on a combined pill whenever we're younger. We tend to be swapped by our GP somewhere around the age of 30 onto a progestogen only type pill because of safety, and we're left on that until we get through to the menopause. What we know is that we're then lacking that little bit of estrogen around the time of the perimenopause, which we don't get from the mini pill or from the Mirena or from the implant or from the injection. So swapping onto a combined pill at that point can be enough for some women. It's also a really good option because we also need to take into account in these years that people can still be fertile. So we're in this world of thinking you're menopausal and therefore you're not fertile, and that's a conversation some people are worried about. But actually, some people do get pregnant. Some people get pregnant in their early 50s. We need to be still really cautious. So the combined pill is a really nice option because it's also giving you the contraceptive benefit, but it's giving you a bit of estrogen, which may again be enough for you to sort out hormones in the background, if that makes sense.
I have a question just come up, so I can put it to you. As a Black woman, I have an increased risk of cancer with the HRT. Is there a lower risk alternative?
So I guess we're maybe going to come up to that to talk about that, aren't we? So HRT is a broad term, isn't it? So what we know is that there are different risks for different types of HRT. So you could call the topical estrogen that we've talked about a hormone replacement therapy, but there is not a risk attached to that. We know that the newer Lancet kind of research that was out in the last year talked about the difference between estrogen only HRT and estrogen and progestogen HRT, with the risk being higher with estrogen and progestogen. So I think we have to be cautious about lumping everything into HRT. Is there a lower risk alternative? Yes, there's lower risks within the world of HRT. There is also another drug that's called Tibolone, which is, I would still class it as an HRT, but its way of working is slightly different and its risks seem to be lower. But again, I wouldn't lump every Black woman into one category, and I wouldn't lump every HRT into one category, but I would suggest that maybe looking at the lower risk things like your topical HRT, like your combined oral contraceptive, like maybe your Tibolone might be better if you're worried about your risks. But I think that'll come up again generally. So I think that conversation could happen again, say to me, if you said to me, my mum had breast cancer, that's the classic one as well, that people will say to me, there's a family history of breast cancer. They would be in the same conversation as being maybe not quite even as much as being Black women, but to do with our personal risks for having cancer and therefore having to make that decision for ourselves.
The GP would take into account your medical history as well as your ethnicity and your genetics, right?
Yeah.
So it's tied into lots of different factors.
It's tied into lots of different factors. And I think as well, to be sympathetic to the GP is that nobody can say 100% that this is not going to, now I am going to word this properly, because what we are knowing is that HRT does not cause cancer, it is giving you estrogen, which may speed up the development of a tumor which is already there. And I think that's the way I've started to visualize it in my head, because I have to have these conversations with women, and they're difficult. Like, can I say for definite that this HRT is not going to harm you? I can't say that for definite. So we just need to be very cautious, and we need to think, what is the benefit for me as a human being versus the risk, and weigh that conversation up.
And I think this takes us to those studies in the early 2000s where these risks with breast cancer were associated with HRT. And the study was flawed in that the people who were assessed perhaps already had cancer. They had a history of cancer in their families. They were obese. They had a history of heart disease. So the cohort that they used weren't kind of the general population. They were already perhaps unwell.
Yeah, and I think they looked at the kind of people who were on continuous HRT, which already then tends to put you into an older age group. So people who were already sort of over 50, and whenever we were getting to the world of kind of starting HRTs. So there were so many different kind of layers on this to do with your own personal story. That means that those statistics don't necessarily hold for you and apply to you. And with obviously that kind of awareness in mind that we all have a risk of breast cancer, and we have things that we do generally. So the kind of statistic I like is that 2 glasses of wine is a higher risk to you than taking HRT. You know, because nobody would think anything really about a couple of glasses of wine, but we think so much about HRT. It's like some of the studies that were put around to do with the vaccine for COVID and those sorts of things. People can change statistics to look a certain way. So, but if you pin someone down and say, is there no risk at all? No one can say yes to that. So that's the problem.
And if you compare it to alcohol again, if you look at the benefits of taking HRT, right, there's no real benefit to taking, well, it's been argued there might be, but there's no real benefit to having alcohol. The benefits, perhaps, it's good that you don't drink alcohol, awesome.
Yeah.
It's good that the benefits outweigh the risks in most cases, right?
Yeah.
So shall we quickly talk there then about the fact that, yes, HRT can help with symptoms, but also the more long-term effects of replacing.
So sure. So I want to go back actually, though, if that's okay. Can I drag us back? Because we were talking about our options, and I think this is where that conversation will come up. So we were talking about if you are younger, we've got the combined pill. We've got our topical estrogen that we can use again if our symptoms are mostly vaginal and sexual related or bladder related. And then we get into the kind of where we're at with kind of HRT generally. And yes, the big benefit that we get as women from being on HRT is our bone health. Big benefit that we have. So if you are under 50 and you have got perimenopausal symptoms, then the benefit most likely, unless you say to me, I have specific risk for breast cancer for me specifically, then the benefit is without any debate. If you're under 50, you should be on HRT at least as a minimum through to the age of 50, 51, average age of menopause, in order to protect your bone health. And then you can start to have a debate with yourself about whether you want to be on it for longer than that to give you additional benefit for your bones. Because we know that our bone health is not just about this skeleton that's within us. Our bone health is so important for everything. So for keeping ourselves moving, for keeping ourselves active, for stopping our kind of arthritises and kind of painful joints and all the kind of symptoms we get around our bone health. But also, if we find that we get thin bones and we have a fall and we break a bone, then statistically that relates to so many other systems from the point of view of ill health afterwards. People do not we do not do well if we start breaking bones, and it's not to do necessarily with the bones. It starts to impact on the rest of our system. So our bone health is really crucial. And if as I say, if you go through perimenopausal symptoms and menopausal symptoms before the age of 50, you really ought to be on something that's replacing those hormones up until the age of 50, 51 at least. And then, as I say, then there's more of a discussion with yourself versus your benefit risk after that point.
Yeah.
We also know that there's benefits for our heart health. And again, these conversations. So if I bring myself into this conversation, that was my big debate with myself. So I don't have breast cancer in my family, but there is heart disease. Maybe it's 2 levels above me, but there is heart disease. I'm Irish, I've got those genes in there. There's cholesterol issues, there's blood pressure issues. Heart disease is one of the things that I want to be cautious about. So HRT for me sits more on a benefit rather than a risk, and therefore I think it's something useful to be on. We know that it's good for memory and Alzheimer's. So we know that as it's being shown to have a protective benefit for the way our memory is. And again, that runs in my family. So that's something that I want to be really cautious about. We know that it's really good. Again, we've brought up sexual dysfunction and things like that, but all of that kind of area, again, getting into more the systemic kind of effects as well, the kind of actual sexual interest and arousal and everything else to do with that side of our life, which sometimes again is uncomfortable to talk about. It's important when it comes to quality of life. Again, can be helped by being on kind of estrogen kind of products and just boosting that estrogen level off, which has dropped at the time of the menopause. So there's so many different benefits that we get from being on estrogen. So we were talking about what kind of forms you can take it in. So then when we, again, if we think historically as a GP, what we used to do then would be to give somebody HRT in the form of a tablet. It was always the one that we were told to give because it was cheapest, and that's being very honest. Patches have been around for quite a long time, but the NHS always has a kind of prescribing list of things that we are meant to prescribe from, and tablets were always the things that were put on it. Before, I guess, some other stuff came out to do with how much better it is for us to have HRT delivered through our skin, there was definitely some evidence coming through that it was beneficial from the point of view of having lower risks to do with DVTs and clotting. But actually, even when that evidence was around, there was still a push for women to be on tablets. I think that push is gone now. We are now allowed to prescribe the patches more. So patches and anything that goes through the skin is now seen as being the safer version of HRT to use. So we have now patches, we have gels, and we have a spray. I have to say I don't have an awful lot of what's the word? I haven't a lot of experience of using the spray or women who are using the spray, but I have a lot of women using the gel. I use the gel myself, and the patches are the other kind of now kind of commonest, I think, way of taking our HRT, mostly because anything that's going through the skin is not being going through the liver, and that's seen as being safer, mostly to do with these clotting kind of disorders. So people who are having blood clots, and I think strokes would probably come in under that list as well.
Yeah.
So if someone is thinking about HRT, the topical stuff's not good enough, the combined pill is not quite good enough either, then I would be encouraging you to think about transdermal, so a patch or a gel, when it comes to your hormonal replacement therapy. If you have a womb in there still, you haven't had a hysterectomy, and equally, if you have had a hysterectomy, but you had a hysterectomy because you've endometriosis, so you might have bits of the womb elsewhere in your body, then you have to be on progesterone as well as your estrogen. So you cannot ever be on what's called unopposed estrogen, because the risk then is there of the womb, of the lining of the womb, even if the womb's not there in someone who's got endometriosis. That's a weird thing to think about with endometriosis, but if you have ever had endometriosis, you should always be on progesterone to balance out the estrogen that's there. So the lovely thing about a patch is you can get patches that have got the estrogen and the progesterone in there. If you have a gel, then you need to think about where the progesterone comes from. So some women will take that as an extra tablet of the progesterone. They'll take it as a vaginal pessary for the progesterone, or they will take it as the Mirena coil, which is a really nice option as well, where they'll get the progesterone delivered to them.
And your doctor will talk to you about what suits you best, the dosage, how you administer it, etc. I'm just aware of time. I've got 2 questions here. Is HRT for bone and heart health mostly if you have menopause before 50?
Is it mostly for if you've got before 50? No, I'm going to say no. So our risk of heart health, obviously, well, maybe not obviously, but it becomes higher as we get older. So our risk of having a heart attack becomes worse as we get older. But what we know is that, I probably worded that wrong. That's why that question's come in. What I'm meaning is that the risks of breast cancer and other kinds of worries that we have about HRT are very small under the age of 50. So if I'm thinking about a benefit risk thing, the benefit under 50 is massive. If you're over 50, you're still definitely getting benefit, but you do then need to start to think about where you sit with regards to the risk, if that's maybe a better way of putting it there. So I know from my, sorry.
I was going to say, it's almost difference between being pretty essential if it's before,
yes,
50, but a really good idea if you're over.
Yes, exactly. Because actually, you know, if for me, exactly that. So because I'm saying to me, my risk personally, because I know my genetics is more likely to be in the heart region, I will stay on my HRT beyond 50, definitely. That's the discussion, but it's essential under 50. I think that's the way I would start to think of it, definitely.
That's great. Next question: are vitamin D supplements enough to support bone health? Exercise.
Yeah, exercise, getting out in daylight. Are they enough to support bone health? I don't know that they are actually. You know, that they might stop aches and pains and your bones not being great, but they are not the same as taking a hormone replacement treatment at all. It's not in the same category. Sorry, I'd love to say it is. It's still good. It's good to do, and I encourage people to do it, but it's not the same.
And also vitamin D has lots of other benefits. Yeah. And we're recommended to take it between September and March in the UK, right? So
absolutely. And the benefits should all be on it now.
Yeah.
Yeah. Lovely. Yeah, definitely.
Is there anything else you specifically want to share? I'm just aware we've got about 5 minutes.
I think the question you thought was going to come up was testosterone, because we haven't talked about that. So often
helpful in terms of libido. Will it help with sex drive, etc.?
Yeah, it does for some people, but I have to say that I have a lot of ladies who, so normally what we will do, we will start with estrogen progesterone. We don't tend to do testosterone on its own, so we will do the progesterone and estrogen first. And then I think because there is a lot on social media to do with testosterone, a lot of people will ask about being put on it. The thing that I find with some people is that it is life-changing, and they go on the testosterone and they feel wonderful. I have a number of ladies who actually feel it's too much for them, so they feel a bit aggressive and they feel unhappy on it. So I think, again, it's one of those ones that is not the one size fits all. Just because somebody on some website is saying this is the thing that you should be on, it absolutely does not mean. And it's another one that people come and say, oh, my levels are low, I've had my blood test done and they're low, and therefore I must need testosterone, and then they take it and they feel awful. So you know, it's not the same for everyone. I also would say if you've been started on an HRT, it can take up to 3 months for you to feel how you're going to feel on it. So again, I have a lot of ladies who've started it, they feel awful, they've got breast tenderness, they feel a bit, you know, they just don't like it, they've had their bleedings become irregular when it's been regular before, and those are the top reasons I have people coming back and saying, I don't know if I like HRT, that's the end of it for me. If you can stick with it for 3 months, you will get to, it's the same as starting a contraceptive, and so try and stick with it.
As soon as you start the rest of the hormones, like when we started out on a contraceptive pill, if you ever took that, it's like you try one, you have intermittent bleeding, or you feel moody or whatever. It's exactly the same thing. It's messing with your hormones. So it's going to take some time to settle and to see what fits you best. Yeah.
And there's a question here about allergies and rashes due to menopause. How do I tell if they are? Probably we don't really know. We don't know until we treat the menopause. So I guess all the list of things that we're talking about treating the menopause, so all the kind of lifestyle things, and then you are getting into the world of HRTs to see whether that helps settle it or not. But again, it depends whether you would rather be on HRT or whether you would rather be on a kind of an anti-allergy kind of medication longer term.
But itching and sensitive skin is a symptom, is a common symptom.
It is a common symptom, definitely. But there's not, you know, there's not a test that someone can do for you that's going to say yes or no to that at all. It's just about, you know, treating the menopause and seeing if it improves, unfortunately.
And I guess if it didn't, then you would perhaps think it was environmental or, like you say, something else. Yeah. I think we've got time for one more quick question from a 73-year-old who I train. She said, is there any point me starting taking HRT now?
I think that there's a broader conversation that comes from that, isn't there, as to why would she? So it was a conversation to do with her and her symptoms and what she's experiencing as to whether there is any benefit versus risk. We
Yeah.
know that it's better to start HRT sooner rather than later. So whenever we get into these risk conversations, although they are low, if we're saying that there is any kind of risk, it is better to start it sooner rather than later. And to be within that first 10 years, again, that is seen as being the best time to be starting HRT. But we have women who do start it in their 70s and very safely and very happily, and it's life-changing for them. So there, again, it's not a one size fits all. It's worth kind of having your kind of sitting with a piece of paper, writing down what's happening for you, writing down what you're hoping to benefit from, what you're experiencing, and again, you know, having a conversation with hopefully a doctor who's able to give you some time to think about those symptoms with you and look at the whole picture with you. You know, as I say, if you find that you're in a practice and you're having a GP who is just saying no to you, and you're absolutely certain you've got perimenopausal symptoms, and you're watching these videos and you've been watched all sorts of things that are on social media, then just go in to see another GP. Most practices will have one person in there who is their menopause lead or women's health lead, and that's annoying. We'd love everybody to know everything, but they can't possibly know everything about everything. So find the one person within that practice, and if you can't even find that, then you can move practices, and then there are private doctors out here who will also kind of chip in and help, even if they just get you started and then hand you back to your GP, which is often what we do, is that we will start you on a medication and send you back, so you don't have to stay under the private system.
Yeah, and being as informed as you possibly can will really help. If you go armed with you can get questionnaires, can't you, on the Balance app, for example. I feel like we could talk for another hour.
I know, it feels like it. We could do another one if you need to, or if people have got questions afterwards,
Yeah.
please just forward them.
Send questions, and I'd love to have another conversation with you, Dr. Claire. That was really helpful, and thank you so much for joining us, guys. I hope to see you again very soon. Thank you.
Bye.
Bye.